Okay, so if you're hearing something new, maybe let's set up a meeting and talk about it. 'Cause this all should sound fairly familiar today. So this is lots of information on your module because I pulled all the information that you've covered in mental health. So you get mental health in 3rd and 4th semesters. In 3rd semester, you cover more of the disorders, what we would find in those. In 4th semesters, it's psych emergency, things like assault, rape, overdose, okay, suicide. I have readings over here from Saunders, and also last semester Dr. Darwin taught y'all in summer mental health, question mark. She probably also included this mental health textbook then, because I've shared that resource with her. I love this mental health textbook, and let me show you why. I don't know. Okay, that's fine. Because it has interactive activities. So have y'all been in this? Do y'all know about this already?
Like, I think we've done this, maybe.
Probably.
It's coming back.
So like, here's your medication one. So if you're like, oh crap, psych meds, that was a long time ago. There's learning activities. So you can go through here and here's some note cards, right? Here's some questions it's gonna test you on. So there's different learning activities in each chapter. If you know there's an area that you're weak in and you want some more practice, great resource to go and get that with. All right, here are recorded lecture videos that you have already had access to, all right? These are my recorded lecture videos for 3rd semester content. There is no recorded lecture videos for the ADHD, autism, and eating disorder, and there's none for the psych emergencies. There's PowerPoints though, so there you are. And then we have these that we're gonna talk about today. Okay, and then there's lots of all adaptive quizzes that you have out there that you are welcome to go do after lecture. Any questions about module stuff? Okay, it's a lot because mental health is a lot. Obviously, I don't expect for you to go through all of this material. Hit the high points. If after today you're like, oh crap, I actually had no idea what depressive disorder was. Maybe go look at the depressive disorder PowerPoint. And go look at the chapter in the book, but don't go read the whole book. You don't have time for that. You've got other stuff going on, okay? All right, so let's do a review from the beginning. All right, so our first slide says, a 28-year-old graduate student presents with excessive worrying occurring more days than not for over 6 months. She reports muscle tension, difficulty sleeping, irritability, and feeling on edge constantly. No panic attacks. What is it?
Generalized anxiety disorder.
Could be nursing school, but it is generalized anxiety disorder. All right, why?
It's over 6 months.
Correct. So this is happening more days than not. Anxious symptoms for over 6 months. Remember, the DSM has a requirement for time for each disorder. For generalized anxiety disorder, it's over 6 months. Okay, so what is one treatment that we can do for generalized anxiety disorder?
SSRIs.
Okay, SSRIs are a great option. Are they gonna work short-term or long-term?
Long-term.
Long-term. What can we do for short-term anxiety?
Therapy, coping mechanisms.
Benzos, yep. Therapy for everyone, right? Therapy is an option for every single disorder we're gonna talk about today, okay? What therapy do we usually like? CBT, which stands for what? Cognitive behavioral therapy, right? Switching the way that we think about things to move the way that we behave about things. All right, do nurses do cognitive behavioral therapy? That's a therapy thing, right? So that's our mental health therapist. So we might refer them to a therapist. We can reinforce things that they learn in cognitive behavioral therapy, but you're not trained to do CBT, okay?
Some of us need CBT, we don't give CBT.
All of us need
Okay, that's how I'm gonna remember it now.
You're welcome.
All right, what is one priority assessment or nursing intervention? What did you say?
Therapeutic milieu.
Okay, therapeutic milieu, what is that?
Creating a safe environment that is like not full of stimulants.
Correct. So what do we want our environment to be like for our anxious patient?
Calm.
Calm. Decrease the stimuli, right? You're not gonna go in your anxious patient, you're gonna go, hey, how you doing today? What's up? How you doing? You good? No, okay, because their anxiety just okay, so make sure you are calm, even if you're well-meaning. We wanna make sure we have a calm demeanor when we're going in and talking with our anxious folks. Any questions about this one? 35-year-old veteran becomes diaphoretic and panicked when hearing fireworks. Avoids crowds and has nightmares 3 to 4 times a week. Symptoms persist for over a year.
PTSD.
This is PTSD. Why?
Triggers.
Okay, we have triggers.
Nightmares.
He's adamantly trying to avoid something, right? Nightmares. Nightmares is a big one with PTSD. What's PTSD stand for?
Post-traumatic stress disorder.
Post-traumatic stress disorder. All right, what risk factor does he have for that? Veteran. Do we see it in other people besides veterans? Absolutely, but very common with our veteran population. All right, what's one treatment we can do for it?
Buspirone.
Okay, buspirone. We didn't talk about that with anxiety. What is buspirone?
It's a mood.
Isn't it SSRI?
Stop smoking.
That's bupropion.
Is it an SSN, like SNR? No.
It's an anxiolytic, so it's in its own little class by itself. It's one of our long-acting anxiety drugs. So we can use SSRIs or SNRIs, but we can also use buspirone. Buspar is the name brand for that medication. Does take several weeks to kick in. Okay, so we could possibly use that. SSRIs are typically our go-to for PTSD, but that's a possibility. Anyone know any other thing we could use for this one?
I feel like it's
Prednisone.
Prazosin, yeah, that's a weird medication. What do we typically use Prazosin for?
It's like an emergency, last resort for
It's specifically triggering the nightmare, so not necessarily last resort. It's a blood pressure medicine though. And if you look it up, you're not gonna see anything in there and that we use it for nightmares. But you will see us prescribe it for nightmares and PTSD specifically. There's also something called EMDR. I know what that is. So it's a therapy that your mental health therapist would do, and it has to do with eye movement. And they use eye movement to kind of reprogram the way that the brain processes that trauma, and it's really effective. All right. What is a priority assessment or nursing intervention?
Suicide risk.
Suicide risk, 100%, high suicide risk with PTSD. So we need to monitor. How would we assess for suicide risk?
Ask them if they have a plan.
Yeah, ask specifically, and there's scales that we can use, right? So there's the PSS, the Patient Safety Screener. There's also the Columbia Suicide Screener, so you may see either one of those. Also need to monitor for substance abuse. We see a high rate of substance use and abuse with PTSD. Why do you think that is?
To try to cope.
100%,
Support
it's a coping mechanism. All right, patient experiences sudden episodes of intense fear with chest pain, shortness of breath, and fear of dying. Episodes peak within 10 minutes and occur unexpectedly. What is this? This is a panic attack. All right, how do you know?
Shortness of breath.
Chest pain, the sudden, it's not all the time.
Okay, it's sudden onset, right? Peaks within about 10 minutes, so it's short. It's not lasting for long periods of time, okay? What is a treatment?
Lorazepam.
Okay, what kind of anxiolytic? What did you say?
Lorazepam?
Lorazepam, which is a what?
Benzo.
It's a benzo. And why would we use a benzo over something like buspirone?
It's quick acting.
We need short acting because this is short, right? So we need it to act now. We don't need for this to kick in a couple of weeks when I'm no longer having a panic attack, or I've had 20 panic attacks until it kicks in, right? I need something that's gonna kick in now. What is a priority assessment or nursing intervention? 100% safety, and why?
They could like get so worked up that they can't breathe good.
Okay.
For hyperventilating.
Physical symptoms of it.
Yep, we do have some physical symptoms. Are they capable of maintaining their own safety if they are in panic? They are not. So we are responsible for maintaining safety. How do we do that? This is terrible.
Calm down.
You can get in the bag, like the bag they can breathe in.
Okay, I like that. Why is that important?
Because you don't want to mess up their CO2.
Correct. What are they at risk for?
Metabolic or respiratory alkalosis.
That is right. All right, these are my 4 levels of anxiety. I have mild, moderate, severe, and panic. All right, at mild, my patient is still able to think logically. They have a heightened sense of awareness. They can actually problem solve a little better with mild anxiety. So mild testing anxiety actually helps you. Okay, moderate, I can still think logically. I'm starting to not be able to make the best decisions, but I can still maintain my own safety. I'm gonna have a little more of those physiological symptoms like racing heart, I might be diaphoretic, right? But I'm still able to be in touch with reality, keep myself safe. Once we get up to the severe and panic, I'm in fight or flight mode. All right, so I can't make decisions to keep myself safe. I'm trying to get away from whatever that panic is, or I am going to fight whatever that is. Okay, so because of that, the nurse is responsible for safety if we get up to severe or panic. Okay, so you're responsible for doing things like using firm language. Okay, it's not time to explain things in long, drawn-out sentences. I don't need them to know the history of why we're doing what we're doing. I need you to sit down and stay here for a minute. All right, firm language, simple language. Right, you stay with your patient, you don't leave them if they are panicking, because again, we're in fight or flight. So they may do something to harm themselves or someone else. Okay, questions about that? We're gonna make sure that we are calm, we're not yelling, hey, I need you to calm down, what are you doing? That's not gonna help their panic, so we're gonna make sure that we are calm. All right, we good with this? Fantastic. All right, what if they're having this and they tell you, I think I'm gonna die, my chest hurts so much.
They might.
Huh?
I mean, they could be.
They could be, what do we do?
They might.
Assess them.
Assess them. Let's do an EKG, right? Let's get a troponin. Let's make sure they're not having a heart attack. Maybe they really are panicking because they're having a heart attack. So don't forget, we have to rule out those physiological causes. We never assume that what's happening is because of a psychological reason. All right. 42-year-old reports persistent sadness for 2 months. Anhedonia, what is anhedonia?
Nothing makes them, there's no pleasure, they don't feel
Correct,
any-
that's an inability to feel pleasure. Low energy, appetite changes, and passive thoughts of not wanting to wake up. What is this?
Suicidal ideation.
Depression.
Okay, this is depression, major depressive disorder. Could be suicidal ideations, but it's currently saying passive thoughts of not wanting to wake up, not thoughts of harming myself. So, definitely some passive concerning thoughts, but maybe not necessarily meeting criteria for suicidal ideations. All right, how do we know that this is depression, major depressive disorder?
It's going on for 2 months.
Okay, we've got 2 months, and what's my time period requirement for depression?
Greater than
2 weeks is correct. And what do I have to have for those 2 weeks?
Consistent symptoms.
Okay, of?
Oh yeah, there's specific ones.
Yeah,
Low
lack of
energy,
interest and.
Right, so there's a whole list, and I need 5 of them. Okay, at least one of those has to be loss of interest in things that were interesting, so anhedonia, that checks that mark. All right, other things that I can experience are low energy. I would not expect high energy, because what would that be? That could be panic or mania, right? Appetite changes, this patient could be eating more or less than baseline, right? And then we have thoughts of death, that's that passive thoughts of not wanting to wake up. All right, what is one treatment option? SSRI, what else we got?
SNRIs.
SNRI, what else?
The MAOIs.
MAOIs? Therapy. But there are 2 other medication classes.
I can't think, the ones that have tyramine in them, is that the MAOIs?
That's MAOIs. You've also got TCAs or tricyclic antidepressants, and then atypicals. That's gonna be something like your bupropion or Wellbutrin, your mirtazapine or Remeron. Your trazodone, which we don't use for depression, but it's in there. What do we use trazodone for? Someone said it. Sleep, 100%. It's given for insomnia, not for depression. All right, SSRIs and SNRIs. What do we know about them?
You're at risk for serotonin syndrome.
you're at risk for serotonin syndrome, and there is a,
Shivers.
yes, shivers. So, in your mental health module, you have this little mental health cheat sheet, which has things like mnemonics on it, like shivers, right? It also has fever or neuroleptic malignant syndrome, so just ways to remember some of this stuff. I like this. I did have AI help me create it, but I proofed it to make sure it was all correct. And so I recommend using this. All right, so serotonin syndrome, what else?
It takes a while.
Huh?
Takes a while and you should.
Takes a while, so this is gonna take a couple of weeks to kick in. All right, they also have this black box warning. What is it?
You're at risk for suicide after like a week or so.
Okay, so what age group?
Adolescents.
Less than 24, so young adults and adolescents, increased risk for suicide. And we look at that right after we started because of what you're talking about. So it's that period where my antidepressant has given me energy, but hasn't really increased my mood and lifted my depression yet. So now I have energy to act on those suicidal thoughts, right? And that's for all antidepressants, not just those two classes. All our antidepressants carry that black box warning. What else? What are our big side effects?
Appetite changes.
Appetite changes. Sexual side effects, and please tell your patients that, okay? Because they don't want to take it if it's going to cause that. They need to know. We want them to tell us so that we can change out their medicines. Not we, but the psychiatrist. Can also cause some headaches. And SSRIs and SNRIs have very similar side effect profiles. SNRIs have a higher incidence of withdrawal symptoms if they stop those medicines abruptly. So you want to make sure you educate your patients not to do that. All right, then we have our atypicals, which bupropion probably has the most to talk about. So let's talk about it, right? Bupropion also does what?
Smoking cessation.
Smoking cessation. What
And
about big
decreases
side
appetite.
effects?
And it decreases appetite, so a lot of people use it for weight loss.
It decreases appetite. So who is not going to get that medicine?
Anorexic.
Anorexic patients, correct. It also decreases your seizure threshold. So who do we have to be careful with?
Epilepsy.
Yeah, anyone with a seizure history. All right, TCAs. What's my big thing about TCAs? Two things.
The lethal in overdose.
They are lethal in overdose, 100%. And they also have big cardiac side effects, all right? So we wanna make sure we're getting baseline EKGs on these patients and we're monitoring EKGs. Anyone with a cardiac history is not a candidate for a TCA. All right, and MAOIs, what's our big thing with them?
Avoid foods that have sour in them.
Why?
If you cause an overdose, then I think.
Increase the availability of drug or something like that.
Puts them at risk for a hypertensive crisis.
Fascinating.
What kind of foods would we be avoiding?
Aged cheese,
Aged things, pickled things.
wine,
Why?
wine.
Wine, yes. All right, what other thing do we need to know about MAOIs regarding other medicines?
They don't play well with.
They do not play well with others. So remember, if you have anything else with serotonin, like any of these other antidepressants that we talked about, there has to be a 2-week buffer on either side of the MAOI. So we have to stop the antidepressant for 2 weeks before we can start an MAOI. And then we have to stop the MAOI for 2 weeks before we can start another antidepressant. Why is that important? Because how do we know if an antidepressant is going to work for someone?
Trial and error.
Trial and error, right? Is MAOI going to be the first thing we go to? Absolutely not, right? There's these food things that my patient has to comply with. There's side effects that aren't great. It's not going to be a first choice. So we're going to have other medicines that we have tried that are failing before we ever get to an MAOI. Okay. How often or how long does it take for these medicines to kick in?
2 weeks.
2 to 3 weeks, sometimes 4, sometimes 6, right? So we've got months in to medication trials before we ever get to an MAOI. Then we have to pull our patient off the medicines for 2 weeks so that we can try an MAOI. All right, and then if that fails, we have to come off for 2 more weeks before we can put them back on something else. So this becomes a really lengthy process. All right. What else can I do besides medicines? And therapy, because we know therapy's good for all of them.
Suicide watch?
Sure, that's a good
Screening.
precaution. It's not gonna treat the depression though.
Coping mechanisms.
Okay, therapy. Yes, but not CBT. That's therapy. ECT. Electroconvulsive therapy, right? Shock treatments. So for shock, ECT, what do we do before the procedure?
NPO.
NPO,
Amen.
pain meds, not before. But we give them a muscle relaxer, that might be what you're thinking of. Why?
Because it hurt.
Because what are we doing with an ECT? We're inducing a seizure. So we're gonna give them muscle relaxants. We're also going to give them something called scopolamine, which is going to decrease secretions. We need informed consent. That means your patient has to be able to make decisions for themselves, or we need to ask the next of kin. And remember, you can't have given them anything that can alter their mind, like a benzo. You can't give them a benzo and then say, here's, have this. All right, after ECT, what do we monitor for?
Level of consciousness, EKG changes.
Okay.
Pain.
Sure. What are my big side effects?
Memory loss.
Memory loss, so you need to reorient. What else? Nausea and vomiting. So we might put them laterally so that if they do vomit, they're not gonna aspirate. And what do you think we need at the bedside?
Suction.
Suction and
Oxygen.
oxygen. What other disorders can we treat ECT with?
Bipolar and schizophrenia.
Correct. All right, what is your priority assessment for this patient? We already said
Suicide risk.
it's suicide risk, 100%. They're saying that they don't want to wake up, we need to assess for suicidality. Any questions? All right. 30-year-old presents with 5 days of decreased need for sleep, pressured speech, grandiosity, impulsive spinning, and distractibility.
Bipolar.
And this is bipolar and they are manic. Yes, how do you know?
Because of the decreased need for sleep.
Decreased need for sleep, what else?
Grandiosity.
Grandiosity,
Impulsiveness.
impulsiveness, and anytime we hear the word impulsive, we should also think safety risk. Because if they're impulsive, they may not think through that decision that might cause them or someone else harm. All right, and distractibility, and that one we use to our benefit, right? So if our bipolar patient is escalating, we might try to distract them. Hey, let's come over here and do this. All right, how do we treat it? Besides ECT.
Lamotrigine.
Okay, what kind of medicine is lamotrigine?
A mood stabilizer.
Okay, what classification?
Oh, I don't know.
It is an anti-seizure medicine.
Oh, anticonvulsant.
Yes, it's an anticonvulsant, so we can use lamotrigine, we can use Depakote or valproic acid is the generic for that.
Lithium. Is that what we use?
Usually before, after you cook it.
I think that got it. And carbazepine is the other one in that class. So we have 3 anticonvulsants that we really talk about with mood stabilization. They all have therapeutic level with them. The only one I care that you really know is Depakote. All right, what's your normal Depakote level? 50 to 100, that's right. All right, why is it important that we know that? What side effects can Depakote have if they have too much? Can cause some liver toxicity and hepatic encephalopathy. All right, so what lab might we check for hepatic encephalopathy?
ASTL.
Okay, we're gonna check the livers. We might also check a lactulose. Okay.
You mean the lactate?
No, that's not what I meant, hold on.
Ammonia.
Yes, that's the one I meant, lactulose is what we treat it with.
I don't know, I didn't know. Wait a minute. Sorry.
So if you have a patient who's on Depakote who came in manic and they seem to be getting better, but now all of a sudden they're confused again, it's probably a good idea to pull a Depakote level on them. All right, lamotrigine. What's your big side effect for lamotrigine? Stevens-Johnson syndrome. It's a pretty big one to cause Stevens-Johnson syndrome. It's one that if they are med non-compliant and they come back and let's say that they were on a dose of 125 milligrams a day, they come back, we're gonna start them real low at about 25 milligrams a day and slowly increase them back up to make sure that they don't get Stevens-Johnson syndrome. Starting them back at their normal dose increases the risk. All right. And then carbazepine doesn't really have any big ones. Questions? Just normal anti-epileptic stuff. All right, what else can we use to treat bipolar disorder? There's 3 medication classes. We talked about 1.
Lithium.
Lithium. What's lithium?
It's a mineral.
It is a mineral. It's a mood stabilizer. All right, it's our gold standard treatment for bipolar disorder. What's my normal lithium level? Therapeutic lithium level. Normal would be 0.
0.6.
That's Tegretol or carbazepine.
0.6 to 1.2.
That's exactly right, 0.6 to 1.2. All right, there's a sodium thing with lithium. What's the sodium thing?
Sodium's good.
Sodium's good. We want them to
Consistent.
consistent sodium level. If they're on a low sodium diet, what's it put them at risk for?
Sensitivity to the makes it toxic.
Correct. Increases risk for toxicity because lithium and sodium compete in the kidneys for the same thing. So if we don't have enough sodium, then they're gonna go lithium toxic. All right, the opposite happens if we have too much sodium, then they might not have enough lithium on board. So we really want them to have a consistent consistent salt diet. These patients are not going to be on, all the words are leaving because I've been clinical today too. A diuretic, that's the word I'm looking for. Why? What do diuretics do?
Because
It's sodium.
They get rid of sodium, correct. What are your symptoms of lithium toxicity?
Let's say hallucination.
Tremors, nausea, vomiting, they can have seizures, have altered mental status, we can see comas, they can die. All right, what's my last class of medications that I can use to treat bipolar disorder?
Can you use antipsychotics?
You can. What generation?
Second generation.
Second generation antipsychotics. We use them in a lower dose for mood stabilization, but yes, that's my 3rd option. And it would be a good option for this patient because they've got the grandiosity. If we had delusions in there, that's another reason for, hey, let's use a second generation antipsychotic, right? All right. What are my priority assessments or nursing interventions for my manic patient? Safety, are they gonna be a risk to themselves or others or both?
Potentially both,
Potentially both. Why?
because of the impulsivity and the grandiosity, they forgot.
Correct. So the impulsivity for sure puts them at risk. So we need to make sure we're maintaining safety. We also need to make sure that we're decreasing stimuli. Right? We're not gonna pull out competitive games. It's not time for Monopoly with our manic patients. That will increase agitation. All right, questions? 22-year-old reports hearing voices commenting on his behavior. He has a flat affect, poor hygiene, and disorganized speech. Symptoms have been present for 8 months. What is this? Schizophrenia. We have positive and negative symptoms of schizophrenia. Does he have positive, negative, or both? Both. What's the positive
The
symptom?
positive is hearing the voices, and then everything else except for the disorganized speech is negative.
Right, so positive is hearing voices and disorganized speech, okay? Negative is flat affect, poor hygiene. Why is it important that it says symptoms for 8 months?
This isn't like from drugs or something short term, I guess.
Okay, so we would rule that out. Anyone know your time requirement for schizophrenia?
6 months.
6 months, so you have to have active symptoms for at least a month with prodromal symptoms happening for about 6 months. All right, how do we treat it?
First and second generation antipsychotics.
First and second generation antipsychotics. First generation antipsychotics have side effects of EPS, which are
Tremors, dyskinesia, akathisia, like Parkinson's.
So we have acute dystonia, which can happen within a couple of hours to a couple of days of starting or increasing that dose of a first gen antipsychotic. What's acute dystonia?
Rigid behavior.
Right, it's that rigidity. Right, so you have like muscle stiffness. And it can look like this, but it can also involve the neck. So if we involve the neck or anything around the mouth, what are we concerned about?
Respiratory. and
Airway, yes. How do we treat it?
Dantrolene, no, benztropine,
Benztropine or
lorazepam.
not lorazepam. That's akathisia.
Benadryl.
Benadryl, yeah, diphenhydramine. So you can use either one. All right, what is akathisia? Ants in your pants, can't sit down. The patient who came in with lots of negative symptoms has been on the unit for a couple of weeks. We started haloperidol, which is first generation antipsychotic, and now they can't stay in their room, right? They have akathisia. How do we treat it? We can use benztropine or diphenhydramine, right? You can also use a benzo to help calm them down. All right, Parkinsonism. What does that look like?
The shuffling gait.
Looks like Parkinson's, okay? So we can use benztropine or diphenhydramine again to treat it. And then the last one is tardive dyskinesia, which is those involuntary movements that your patient makes. How do we screen for these? AIM scale. All right, so AIM stands for, what is the A? Something involuntary movement scale. I'll get back to you with the A. We do these at outpatient appointments, and what you're looking at is there any change from baseline? So there's not necessarily a score on the AIM scale that's gonna tell you, hey, this is high or this is low. What you're looking at is deviation from baseline. Okay, and if we have deviation from baseline, the physician needs to know, and we need to look at changing those medicines. Your patient may also be prescribed benztropine or diphenhydramine if they're on a first generation antipsychotic routinely. Right, so if they have diphenhydramine scheduled every day and they're also on haloperidol, it's probably not for their allergies, it's probably to prevent extrapyramidal symptoms. All right, besides extrapyramidal symptoms, what's my big side effect profile for first generation antipsychotics?
NMS,
Okay, we can have neuroleptic malignant syndrome. Okay, what's that?
I think you have like a high fever,
Mm-hmm.
and then blood pressure.
Yeah, you've got blood pressure lability, you've got high temperature, you've got that lead pipe rigidity. What do we do for it?
Dantrolene.
Dantrolene, get them up to ICU. Okay, they're no longer a patient on the psych floor. Also can cause anticholinergic effects though, which Benadryl is what kind of medicine? And anticholinergic, okay? What are my big anticholinergic effects? Drying. So as a nurse, what am I concerned about for my patient who might have anticholinergic effects?
Urinary output.
Okay, urinary retention, orthostatic hypotension, constipation, right? All right, second generation antipsychotics can also cause extrapyramidal symptoms, but they're not as likely to do so. They're more likely to cause metabolic symptoms. So what would I be assessing for with metabolic symptoms?
Bowel sounds.
What'd you say?
Bowel sounds.
Not bowel sounds. Good guess. What is metabolic syndrome? Metabolic syndrome is a cluster of things that increases your risk for stroke, diabetes, heart attack, okay? So this is gonna be hyperlipidemia, obesity, hypertension. So we're gonna monitor those things, right? We're gonna monitor blood glucose, we're gonna monitor their weight, we're gonna monitor their HDLs and LDLs. Questions about first versus second generation antipsychotics? Remember, there are also long-acting injectables available for some of these medicines in both first and second generation antipsychotic. Why would a long-acting injectable be preferred for my patient?
Medication.
Correct, it helps with medication compliance. All right, any questions about this? Okay, what's my priority assessment?
Command hallucination.
Command hallucinations. I need to ask him what those voices are saying, right? They're commenting on his behavior. Are they telling him to do something? Are they telling him to hurt someone? We need to assess for command hallucinations. All right, history of unstable relationships, fear of abandonment, self-harm behaviors, and emotional lability. I'll give you a hint, this is a personality disorder. What do you say? BPD, which stands for? Borderline personality disorder. How do you know?
Unstable.
Huh?
Unstable.
Okay, unstable what? Right, so unstable relationships, that's very characteristics of borderlines. They also have this splitting behavior where they see people as either all good or all bad. And that causes lots of problems in their relationships. Right, and we could see kind of how this could develop because ACEs are often a risk factor for personality disorders. What are ACEs?
Childhood disorder.
Adverse childhood events. So that's going to be things like abuse in the home, either towards the child or to someone living in the home. It's going to be abandonment of a parent, either through divorce or going to prison. Somehow parent left the home. It could also be things that they witnessed in the community. So if there was violence in the community, like the shooting that happened in Dadeville a couple of years ago, that would be an adverse childhood event. So things that are going to impact them long term. And if you have someone who is being abused, and you can see how seeing that parent as all bad in the middle of abuse is helpful, right? It's self-protective. But when they're not in an abuse situation, this is still the person who's responsible for giving me love and providing me with food and giving me safety and shelter. So seeing them all good, again, is very self-serving to the child. But what happens is as they get older, they don't see that, and they're unable to see that that's not how people are, that people are all a little gray, and it causes issues in their relationship. what do I do to treat borderline personality disorder? What'd you say?
Therapy.
Therapy. Is there a medication to treat personality? No. Okay, you cannot give someone a pill and make their personality better. It's through therapy. All right, what is your priority assessment or nursing intervention?
Suicidal.
Okay, suicide for sure. Is this patient gonna tell you they're currently suicidal?
No.
Probably not, okay? Once they get to the unit, they're usually no longer suicidal because whatever event that was happening is not currently happening. What we need to work on is coping skills. So when they're in the middle of a crisis again, this is not their go-to, okay? How do we work on that? What's that called? Someone said it earlier. Safety plan. They need a safety plan before they go home. What's the safety plan?
Contract.
It's their guide on what they're gonna do when they're in a mental health crisis. Right, so just like we don't decide where our safe place is in our home when the tornado's over our house, you don't wanna know what your safety plan is in the middle of a mental health crisis. It's gonna lay out things like your coping skills, what your triggers are, who your safe people are, what your emergency phone numbers are, if you have a safe place where that is. It's all figured out so that you don't have to think about that in the middle of a mental health crisis. Questions on this? All right. What time is it? Okay, we're good. All right, grandiose, lack sympathy. Exploitive behavior requires admiration. This is also a personality.
Narcissistic personality.
This is narcissistic personality disorder. All right, with those cluster Bs, which is borderline personality disorder, antisocial, narcissistic, histrionic, remember these patients often are manipulative. They will interact with others. So remember, antisocial does not mean asocial. Antisocial personality disorder people are very social, but they will interact for their own benefit. A lot of your serial killers, antisocial personality disorder. All right, and they didn't kill people by staying in their house and not talking to people. Okay, so questions? That was maybe not the best line I've ever had. All right, we treat personality disorders the same. It's therapy. Remember, on the unit, we need boundaries, limits. Don't give them all your information. You shouldn't be doing that to anyone, right? But you wanna make sure you have really good professional boundaries. We have boundaries on their behavior. If it's not snack time, they don't get a snack. Because if you give them a snack and then tonight they don't give them a snack, then you're the best person in the world and this night shift person doesn't know what they're doing and how do they ever become a nurse? So remember, consistent, firm boundaries across the board. All right, questions? Okay. All right, BMI of 15, so already I'm thinking what?
Anorexia.
Anorexia. Intense fear of gaining weight, distorted body image, and bradycardia. Remember, the differentiating factor between anorexia and bulimia is the low BMI. So both of them can have purging behaviors, but that low BMI is what is gonna differentiate between anorexia and bulimia. You have to have a low BMI to get a diagnosis of anorexia. All right, what do we know about anorexia? Serious or not serious?
Serious.
How serious?
How's
Like, it can be life-threatening.
It's the most lethal mental illness that we have. It's a big deal. All right. This distorted body image is also very diagnostic. So even though they have a low BMI, they're gonna look at themselves as fat, as obese. Okay, they do not see themselves in reality. How do we treat it? Therapy.
Dietary,
We definitely need to include dietary.
disassociating like the badness with food and like pretty much reassociating it with something else.
Yep, so we're gonna work on that with therapy. Is there a medicine we can use?
If they're anxious, you might go give them Oh, yeah.
Weed?
You could give them an anti-appetite stimulant. Let me tell you how that's gonna go though. Your patient who has a distorted body image and has a very big fear of gaining weight is gonna ask you what this medicine is for. And you can't lie to them and tell them that it doesn't have a side effect of gaining weight. So are they gonna take that medicine? Probably not. If they are, it's gonna be way into therapy. So good in theory, probably not gonna work in practice. We can use fluoxetine. So it's actually approved for anorexia in a higher dose. And there's lots of things we need to do on the unit while we're making sure this patient is safe before they go back home. So what would we do on the unit? Let's talk about what we won't do. So, are they gonna be forced to eat? No, you can't force someone to eat. Now, might we give them an NG tube if they're not maintaining their BMI? We might need to do that. And we would talk to them about that. But it's not gonna be, oh, you didn't make good choices today, so I'm gonna punish you by giving you an NG tube. Remember, nothing that we do is punishment, including restraints. It's not punitive. We might have to do some things because it's in the best interest of the patient to keep safety, right? We can't let them die. But it's not punitive. Okay. Surrounding meal times, we're gonna lock them out of the bathroom for 30 minutes or they're gonna be a lot of sight. Why?
Make sure that they're not purging.
Make sure they're not purging, because if they're eating, they're probably gonna have some guilt surrounded with that, and they may try to purge because of that. So we make sure we have lots of close monitoring, and we usually just lock them out of the bathroom after meal times. All right, physiologically, what am I concerned about?
Cardiac arrest.
Okay, I'm definitely concerned about cardiac arrest. We've got bradycardia, so they are at risk for some arrhythmias.
Electrolytes.
They are at risk for electrolyte issues. Okay, and when we start feeding them, especially if they haven't been eating, so if they've been eating nothing or negligible amounts for more than 5 days, they're at risk for something called refeeding syndrome. Y'all heard of this?
Mm-hmm.
Okay, what's your big sign of refeeding syndrome?
GI.
So we're gonna monitor phosphorus.
Mhm.
So we've got low phosphorus, right? We can have low potassium, low magnesium. We're gonna watch those electrolytes. They can also have signs of heart failure. So we can see some fluid overload type things, edema, pulmonary edema, where we hear crackles in the lungs because of the shifting of things, because they haven't been eating. So when we start reintroducing nutrition, we can have fluid shifts because they haven't had it in their body. So we need to make sure we're monitoring heart and lungs closely. Any questions about that? Okay. Moving on, recurrent binge eating followed by purging, normal BMI. This is bulimia. We do a lot of the same things for bulimia that we do for anorexia with the locking out after meal times. How do we treat bulimia? Yep, therapy for sure. There is actually a stimulant we can use for binge eating, if it's just binge eating, but for bulimia, it's therapy. We can treat underlying depression and anxiety if it's there, but there's no medicine that's gonna treat it. What signs would I see different in bulimia than I would in anorexia?
Something in their throat will look
Corroding
different.
teeth. and
Okay, yep.
esophagus.
Yep, so we can see esophageal erosions. We can see thinning of the enamel on the teeth. Why?
Because of that acid.
Because of the purging. And we could see that in anorexia if they have purging, but you don't always purge in anorexia. What about knuckles?
Calluses.
Calluses, and that's called something. What's that called?
Russell's.
Russell sign. What would we see in anorexia that we wouldn't necessarily see in bulimia? Besides the BMI.
I was gonna say low calcium.
So we could see some more electrolyte abnormalities. We can see electrolyte abnormalities with bulimia too because of the purging. So it's gonna be secondary to the vomiting, diarrhea, however they're purging. We can also see lanugo in anorexia. What's lanugo?
The hair.
The hair. Right, so we should really only see that in babies, so it's that fine dowy hair. Can also see no menstruation due to the low BMI. They have fragile bones, so they're more at risk for fractures and osteoporosis. All right, questions about eating disorders? All right. Tremors, diaphoresis, tachycardia 12 hours after their last drink.
Alcohol withdrawals.
This is alcohol withdrawal. How do we assess for alcohol use disorder?
See me?
No, what's the scale that we use?
Cages.
Cages.
So the cages assessment, right, wants to know how often you drink, have you ever felt guilty about drinking, have you ever had a drink first thing in the morning? So that's the questionnaire we would do on admission to tell us if we need to be watching this patient for withdrawal, right? At this point, 12 hours in, we're gonna use what scale?
See,
CWA. So now it's time to use CWA, which is assessing for withdrawal symptoms. Okay. A patient with alcohol withdrawal, what kind of complications are they at risk for?
seizures,
Seizures? What else?
cardiac dysrhythmia,
Okay, cardiac dysrhythmias,
kidney failure,
kidney what?
like kidney failure.
Okay, maybe kidney failure.
Hallucinations.
Hallucinations. And that would be if we got into what? Right, so that's gonna be more common in DTs. Also at risk for death, right? They can have a heart attack, they can have an embolism, they can commit suicide when they're in withdrawal. So lots of things working against them there. How do we treat alcohol withdrawal?
Hospitalization,
Hospitalization, what are we doing in the hospital?
fluids,
Okay, what's in those fluids?
like banana, bag,
Electrolytes, a banana bag, what's in a banana bag?
B12, thiamine,
Okay, thiamine, that's what turns it yellow. Multivitamin, yes. And my patient is at risk for something called Wernicke's encephalopathy. So I have to make sure I give that thiamine before I give dextrose so that they don't have Wernicke's encephalopathy. All right, what electrolyte do I need to watch carefully? And think about torsades. Magnesium. These patients are at risk for hypomagnesia, which puts them at risk for VTAC. All right, what else do I use to treat withdrawals? Okay, definitely not, but I know what you're thinking. Benzos, yes. Disulfiram is what?
It makes you stop drinking.
Makes you stop drinking. We don't give that during withdrawal. So that would be after my patient has come out of withdrawal, they have made a conscious decision that they want to stop drinking. Because if they have any alcohol on disulfiram, what happens?
They throw up.
They violently vomit. Okay, so we want them to be able to commit to that, make an informed decision before we start them on that. All right, benzos, great drug. Why am I using it in withdrawal? Okay, CNS depressants is gonna help calm my patient down. It's also gonna help prevent what?
Seizures.
Seizures, yes, so we like it, okay? It is my go-to drug for treating the symptoms. The other things are great for electrolyte repletion, for nutrition. Benzos is gonna help prevent my withdrawal symptoms. All right, pinpoint pupils, respiratory depression, decreased level of consciousness. Opioid overdose, yes, all right, pinpoint pupils, respiratory depression, this is very consistent with opioid overdose. How do you treat it? Naloxone, yes. All right, you give naloxone and then what do?
You reassess and then you give it again if they're still not back.
Correct, you may need to redose, so make sure you know that it could wear off, the opioids could still be on board, you may need to redose. Continue monitoring. All right, limited eye contact, repetitive behaviors, delayed speech, rigid routines.
Obsessive.
Someone said it.
I said autism.
That's correct. This is autism. Why is this autism and not OCD?
Repetitive behaviors and delayed speech.
Correct.
Speech.
And limited eye contact. Okay, those are characteristic of autism. Remember, autism is a spectrum. So it's autism spectrum disorder. You can have patients who are very high functioning, who have a diagnosis of autism spectrum disorder. You can have patients who are nonverbal and need a lot of assistance. So our outcomes are geared toward maximizing whatever that patient is capable of. It's gonna be very patient specific. Safety concerns include some of these repetitive behaviors can be head hitting. So it can be self-injurious. We wanna monitor and prevent that. And they can also elope, so they can get overwhelmed and run away. So we wanna make sure that that doesn't happen. I was on the unit today, 23-year-old admitted for eloping from their home with autism. All right, questions. How do we treat autism?
There's a lot of therapy, there's a lot of programs. I know there's one up like a.
Yeah, there's a lot of therapy. Is there a medicine that will treat autism? No. When do we see symptoms appear?
2 to 3 years old.
Right, so we should see them by 2 to 3 in order for to have a diagnosis of autism spectrum disorder. What symptoms do we see around 2 to 3, or even earlier?
Lack of speaking.
Okay, speech delay, eye contact, those social things, right? So that back and forth speech, that eye contact, smiling at parents, right? We wouldn't see that happen in a normal progression. All right, questions? Okay, what can I do to help support my patient with autism?
Keep a routine.
Keep a routine. If we can keep that caregiver at their bedside, let's do that. That's gonna help them.
Stimulation.
Okay, stimulation. Some of them need stimulation, some of them can't handle stimulation. So figure out where your patient is. Okay, they may need headphones because it's too loud. The lights may be too much. Think about putting your autistic patient near the nurse's station with all the whistles and bells and people moving. That's probably gonna be too much for them. All right, so consider where you're putting your patients. Routines are really beneficial. That's hard to do in the hospital, but let's do it as much as possible. If we're looking in the school setting or we're looking at educating teachers, then we can do visual schedules are really helpful so that they know what's coming next. And also transition warnings. So rather than, hey, it's time to go do this, hey, in 2 minutes, we're gonna move to the next room. So give them a warning. All right, impulsivity, hyperactivity, difficulty sustaining attention in multiple settings.
ADHD.
This is ADHD. When do we see symptoms of ADHD?
Between 5 and 6.
Okay, could be between 5 and 6, has to be before age 12 in order to get a diagnosis. Does that mean you cannot be diagnosed as an adult? No. The DSM though says that you have to have some symptoms that happen before you were 12. Okay? All right, what are our big concerns for ADHD?
Impulsivity.
Impulsivity means,
That they just do whatever.
right, it's a risk, okay? If I'm impulsive, I might not think it through. How do we treat ADHD?
Medication.
We can do medication. Is it our first line?
Probably not.
No. Why?
Because it shouldn't be.
Okay, so let's talk about our medications. Gold standard is a stimulant. What are my side effects for stimulants?
Maybe make them stay awake, which causes even more issues.
Okay,
They're addictive.
they can be addictive, so they are a controlled substance.
Suppress appetite.
They suppress the appetite.
Decrease sleep.
They can decrease sleep. They can cause behavioral changes. They can decrease growth. Okay, so we have lots of side effects that aren't great, especially in a kiddo who's supposed to be eating and growing, right? So stimulants are not my first line, but they are definitely used and recommended if we need it. So what's my first line? What do I try before I go to stimulants?
Behavior modification.
Yeah, what behavior modification would we do? Or how would we support this patient?
Redirecting.
Okay. It's some of the same stuff we talked about in autism. Schedules are great. Visual schedules, also great, all right? Making things competitive in a game for your ADHD kids, very beneficial. It gives them that dopamine hit, they wanna do it. What about screen time?
Especially when it's screen time.
Yeah, everyone needs limited screen time. Screen time is not causing ADHD, but it's not gonna help the symptoms. Okay, so we wanna limit screen time. All right, besides stimulants, there's another class of medications we can use. What's that?
Anxiety.
Guaifenesin.
Guaifenesin is what kind of medicine? Guanfazine is an expectorant, so we have guaifenesin. Guanfazine is the one we're talking about now.
Very confusing.
They sound similar. So what's guanfacine?
I have no idea.
So it's a non-stimulant. Someone look up guanfacine. Tell me what the class
Is it
is.
newer medication?
It's not a newer medication. So we
Is it
have.
cold medicine?
Huh?
Or is that the other?
Not guan, not Mucinex.
Chuck, you said guaifenesin is messed
I
up.
know, it's-
We're not gonna look at it now.
It's a blood pressure med?
Yeah.
Yep.
Another blood pressure med we use, clonidine. Right, so these are gonna help more with that impulsivity and hyperactivity rather than helping attention.
It's like a lower dose of clonidine
No, well, 0.1, which is, I mean, generally your starting dose for adults for blood pressure as well.
seems kinda weird to give clonidine.
Yep, so it is still gonna affect your blood pressure, but if you have a 6-year-old on clonidine, it's not for blood pressure,
Yeah.
it's for ADHD.
Also used for Tourette.
Huh?
It's also used for Tourette.
Clonidine's a weird drug.
Yeah, so it's guafin, not guaifenesin.
Not guaifenesin, guanfacine.
Guanfacine, I guess, also used for Tourette's too. And it's
Weird cardiac drugs.
What's the other name?
Huh?
Does it have a,
Tenet,
Oh, yeah.
I've never heard of it either.
T-E-N-E-X.
Strattera.
Strattera is amoxicillin, so we can use that one. Tell me the class for Strattera.
It's a selective norepinephrine.
So it's an SNRI, it's an antidepressant. So weird other drugs that we can use for ADHD. If they're on a stimulant, tell me the things that we're monitoring.
Appetite,
Appetite,
Heart rate,
growth.
heart rate,
blood pressure.
blood pressure. It can cause cardiac issues, so we're gonna screen for that before we start them on a stimulant.
Mhm.
And how would we screen a 6-year-old for cardiac issues? You're gonna ask if there's any in their immediate family. So is there a history with parents? Obviously, we would check their blood pressure and heart rate, but we need to know if parents have something. All right, we also need to monitor height and weight
For growth.
for growth. Mhm.
And then, like how it's actually, if it's actually working.
Right, for efficacy. How would we educate our parents to maintain appetite?
Like schedule, like, we're gonna do
Give
this
it to them
time.
in the morning, that way.
So give them the med in the morning, give them a good breakfast, high protein snacks throughout the day. Because they're probably not gonna eat a lot, so give them high protein little snacks throughout the day.
And then usually it starts working on 5 days.
Yep, so what time do we really wanna get that last dose?
If you have to give it twice a day,
Yep.
like,
Would we schedule it
Late
for
dinner.
morning and bedtime?
no, lunch.
Lunch or before 3, usually 3 is our cutoff time, because we want them to be able to sleep at night. All right, questions? Okay. All right, psych emergencies, let's talk it through. A 6-year-old presents with bruises in various stages of healing. The parent says he's just clumsy. The child avoids eye contact and flinches when touched. What do we think is going on here?
Child abuse.
This is child abuse. What is our responsibility?
We are
So,
report.
We are mandatory reporters for children, elderly, and protected adults. All right, this is a child, so we would report this. What do we need to do right now? Okay, we need to keep the child safe. We need to do a physical assessment. Okay, what diagnostic tests might they order?
Ultrasound or radiograph.
Okay.
Is your staging of breaks.
Yep, so we
bruising.
might look at x-rays. We're looking for old fractures that might not have healed properly because they might not have been cared for. Toddler is admitted with severe diaper rash, malnutrition, and poor hygiene. Caregiver appears indifferent. What's this?
Neglect.
This is neglect, okay? What is our responsibility?
Report.
We are mandatory reporters. 82-year-old woman presents with a hip fracture. Her adult son answers all questions. She appears fearful and whispers, "I don't want to go home."
Elderly abuse.
This is elder abuse, okay? Are we a mandatory reporter?
Yes.
Yes, we are. 28-year-old pregnant patient presents with facial bruising. Partner insists on staying in the room.
Abuse, but not reportable.
Correct, unless they want it to be. So patient gets a say-so.
What if, because she's pregnant?
That gets tricky.
Because you have a dutiful assignment for the child.
Correct. So that we're gonna loop social work in on, to help us make some decisions here. But for the 28-year-old pregnant patient, we are not required to report, because they're 28. So, pregnancy complicates it. We're gonna need to loop in social work and see.
Because if
It
you do a
matters how
fetal
far along
assessment-
she is, right. What do we do about the partner insisting on staying in the room?
Try to get her alone if we can.
Right, we need to get security involved. Ideally, we could just maybe go ask him to sign some papers so that we can assess our patient one-on-one,
Take her for your house.
or take her, right, for a test. But we may need to get security involved, and we definitely at least want to let them know in case things escalate. Patient discloses intimate partner violence, but states she is not ready to leave the partner. What do we do?
A safety plan.
A safety plan, which includes,
A person that they can go to, a plan to leave, and
The phone number, contact information for, like, domestic violence shelter or something.
right, and we're gonna give that discreetly. We're not gonna write shelter information and then put the phone number, because if the partner finds out, that may be a reason for abuse to happen again. So we want to very discreetly give resource information. A 19-year-old arrived stating she was sexually assaulted 3 hours ago. She has not changed clothes. What do we do?
preserve evidence.
Okay, who do we call?
Same.
SANE nurse. SANE stands for what?
Sexual assault, nursing.
Sexual assault nurse examiner. Do y'all watch The Pit? Because The Pit did a really good job of talking through SANE stuff. So yeah, sexual assault nurse examiner. So that nurse is gonna come. Ideally, your hospital has one. Not everyone does. But they're gonna come and stay with that patient. They're gonna go through the process of collecting evidence. Do we call the police?
If she wants you to do.
If she wants you to. She's 19, so she's not required to press charges. All right, do we have to have consent before we collect evidence?
Yes,
Yes, we do, right? How do we want to collect evidence?
strategically.
Very strategically. Remember, we want to chart objectively, exactly what we see, exactly what the patient says. We don't want to infer things. We want to document with objective assessments and pictures. We have to have consent for pictures.
I had people on it, there was a singer that she let me go in and
Yeah.
watch her. It was a really interesting process, cause it's not sterile, but it kinda almost is.
Right.
They have to have a new box of gloves, and they change clothes in between every single thing they do.
Mm-hmm.
They open their pack of swabs and they use it immediately, and then immediately seal it. Like, it was a really interesting process.
Why are they doing it that way? Did she
So
tell you?
they cross contamination, make sure, yeah.
right? So we wanna make sure anything that's collected is the patient or the perpetrator, that we're not giving anything on there that we shouldn't be. So, yeah, I'm glad you got to see that. That's an interesting experience. Unresponsive patient, respirations are 6 per minute, pinpoint pupils. Narcanum, right? Because this very much looks like opioid overdose.
Twice from,
What are my priorities?
stabilization.
Stabilization, okay? Airway, they're only breathing 6 times a minute, that's not enough. Okay, so I need to support that. How do I support that?
2.
Maybe,
O2.
Oh, yeah, intubation.
maybe intubation.
At least oxygen.
Yeah, at least let's do some oxygen. Let's Narcan them, see if we can get them breathing. Probably gonna have to intubate them. Okay, questions about this one? Remember, when you're looking at priorities, ABC doesn't go away. They are not gonna hurt you if they're not breathing. So we have to get them to breathe before we can worry about safety.
So would you, if it was a priority question, would you give oxygen first or give no oxygen first?
You would give oxygen first, ABCs.
And then you would, thank you.
Patient pacing, clenching fists, loud voice, refusing redirection.
Ativan.
Maybe. What do we do first?
Assessment.
Okay. We assessed, they're agitated.
Probably need some help.
De-escalate, yes, how do we de-escalate?
Police.
Okay, reduce environmental stimuli.
Don't be alone with them.
Don't be alone with them.
Police, Ativan.
Not yet, we're not ready for Ativan yet, right? Maybe they have a legitimate concern, so we're going to give them the opportunity to voice their concern as long as they can do so safely. All right, we're gonna have open posture, right? Remember all that therapeutic communication stuff. Allow them to talk. Now, if they continue to pace and threaten and they're escalating, who do we need to be with us? Security. Ideally, we've already called them because we can see that this patient is upset. So let's go ahead and get someone else involved in case this continues to escalate. All right? If this continues to escalate, then I might give them medicines. I might give them Ativan. I probably, if they're on the psych unit, have an order for Haldol Ativan to give PRN severe agitation. If this continues, that's gonna meet severe agitation requirement. Let's say I go to give that shot and they start swinging on me, then what do? Restraints. What if they swing on me? I say, hey, stop, go to your room, and they go to their room.
Okay, then I guess
Then we're not putting them in restraints. Remember, restraints are always a last resort. They're never punitive. It's not because you were acting a fool on the unit, I'm gonna put you in restraints, right? It's always you're going in restraints because you can't maintain safety for yourself or those around you, okay? So if we put them in restraints, how often do we document? Every 15 minutes. Remember, you have to have an order. You can never, ever, ever have a PRN order for restraints, and that goes for medical or behavioral. These would be what kind? These would be behavioral restraints. All right, every 15 minutes we're documenting where those restraints are located, what kind of restraints they're in. My patient's behavior, because I need to know that they still meet criteria for restraints. If they don't, if they're asleep, where should they be? Out of the restraints. They shouldn't be sleeping in restraints. All right? I'm also going to document things that I'm doing to try to get them out of restraints. Maybe I'm trying to negotiate with them. Maybe I have increased monitoring. I 100% have, because I put them line of sight. I'm watching them while they're in restraints. All right? Within an hour of going in those restraints, they need a head-to-toe assessment. Okay? They need a blood pressure. We're going to listen to their heart and lungs. We're going to do the best head-to-toe assessment we can do without taking them out, flipping them over, and looking at their butt. Right? Why do we need to do a head-to-toe assessment?
So you can document.
So you can document, yes, because why? Yeah, why are they at risk for injury? Yeah, because if they just walked down and laid in your restraints nicely, they probably would have walked to their room and not met criteria for restraints. So it's usually an altercation to get them in restraints, which increases their risk for injury. It also increases your staff's risk for injury. So make sure you're also talking to your staff and debriefing with them after the restraint. Alright, once we get them out of restraints, we're gonna debrief for them, we're gonna talk about, hey, what led to this restraint? What can we do a little bit different next time? Okay, what coping skills can we use? That might have to wait till they wake up, because we're also giving them medicines when we put them in restraints, and they may be taking a little nap when we take them out of restraints. So we'll debrief with them when they wake up. Okay, questions? Alright. Oh, what is the first priority for a sexual assault and bleeding?
Address them.
Injuries, right? Stabilization. They're bleeding, we need to make sure they're stable. Remember, ABCs always take priority. All right, if you have intimate partner violence and a strangulation history, airway, 100%. We also need to assess for carotid injury. All right, child abuse suspicion.
Injuries.
Injuries, mandatory reporters. Overdose, unknown substance. What are we gonna do?
Naloxone.
Naloxone and
Airway.
airway and
Assess.
Test. Would you check to see what substance they possibly ingested?
yeah. There's another antidote we could give though. Flumazenil. That's my antidote for what? Benzos. I do have to be careful giving flumazenil, especially if my patient has been on benzos routinely, because if I give it, it increases the risk for seizures.
Mhm.
Now, if they're not breathing,
I mean, seizures aren't a problem.
seizures are alive, right? So, all right, escalating patient, what do we do? De-escalate. Remember, we're calm. We're gonna allow them to voice their concerns. We're gonna have our friends with us so that we don't have to handle this by ourselves. And if our patient continues to escalate, then we will continue to escalate interventions. Restraints are always a last resort. We have to try other things first. Questions? All right, take a 10-minute break. Oh, no, we end at 7, don't we?